A revolutionary custom knee replacement procedure can be life-changing for patients with debilitating knee pain.
So today on Health Talk, we'll discuss this new technology with an orthopedic surgeon who performs the procedure and a patient who has benefited from it.
So stay tuned. Eric and I are up next. Hello, I'm Dr. Vicki Smitak.
And I'm Dr. Eric Mazer. Today we're going to talk about custom knee implants with Dr. Michael Lynch, orthopedic surgeon with Coastal Orthopedics, and his patient, Alan DePietro.
Yes.
Did I get
Welcome.
that right? Or?
You did, yes.
So thank you both for coming on the show. We're happy to have you, and we're going to talk about this very specialized sort of custom knee replacement procedure that you're doing, Michael. But before we get to that sort of punchline, let's talk a little bit about knee surgery. You know,
Yeah,
things
it seems
that
like
brought
everybody,
you
if you
to-
live long enough, you get knee pain at some
Everybody gets
point.
knee pain, right? I have
So
knee
keeps,
pain right
keeps
now.
you in business. But you know what differentiates ordinary knee pain from stuff where they should start to think about joint replacement?
Well, I think it's the severity and the chronicity of it and the inability to manage it through things like anti-inflammatory medicines and injections and physical therapy, all of which you should try first. But I think the thing, and Alan can expand on this, but I think the thing that gets the person to really contemplate is when they're missing out on things in life. Somebody wants to go shopping and they kind of hang back, or they'd like to do more and they can't. And that's the time when we have the technology to get them back in the game.
Were you finding that to be the case, Alan? You wanted to go to the mall, but you couldn't quite make it there? I'm being facetious. I'm sure there were other
Was
things.
it shopping that
I think
got you,
that
or was it-
pertains to the female part of the people that need knees.
But tell us a little bit about
tell
your
us your story.
Through my life, I've had many knee surgeries, probably about 6 prior to the replacement, through sports and other things happening to my knees, and it just got worse.
So you're pretty active guy? in terms of-
Earlier, yeah, I was very heavily into sports when I was a kid, and was on the fire department for 31 years, so I did a lot of kind of beating up on myself for many years and not realizing what it does to you. That and the gene pool wasn't so good to me with the arthritis either, so that kind of really
Actually, I was
threw a
gonna ask
curveball
that.
in there.
I was going to ask Mike that, whether, you know, how often this is related to sort of family history. Do people have a tendency for this osteoarthritis as well as just kind of a vigorous history of it, of exposing the joints to damage as well?
Yeah, there's no question that there's a predisposition in certain families. It runs high. That's a common question I ask to sort that out. So there's a predisposition, and then there's trauma and other factors that can accelerate the process.
So I'm going to go a little bit on a tangent with what you said, Alan, as far as being very actively into sports from a young age and stuff like that. And I'll ask you, Mike, do we expect to see that a lot more? I mean, you know, kids are active and they play sports pretty competitively. I mean, from what I see, not just in Fairfield County, but I think nationwide, there are communities where kids are just a lot more vigorously trained in sports from a very early age, and that puts wear and tear on knees right over, you know, our young adult life, et cetera. So are we going to see needing knee replacements at like 40 and 30, and what's the trend going to be in the next 10 years or so, or 20 or 30 years?
It has been and continues to increase. It starts with more sports injuries in the younger ages, because there's this more participation in single sport activities, commitments. Kids are committing sooner. So
You know, that's an interesting point, because I've read that too, that it's not just the kids are active, because we were all active, but now kids are getting into
but this is
competitive sport
specialty
in a defined area, and that does put more stress on the joints oftentimes.
And I mean, the only thing that's going in the right direction is people are generally more health conscious and taking care of their weight and not letting that run. But my parents weren't as active as this generation is, and so they didn't have the need for knee replacements. That wasn't holding them back, but these people want to keep running and doing marathons. And
that's another interesting point, because I think, I look back at my parents, and by the time my father was my age, he'd pretty much retired from doing anything active. And, you know, I still ski, and I still like to hike, and I like to get out there and build up a good sweat. So our expectations are getting different as we get older.
That's correct. It's a different paradigm now, and we're here to try to keep it going.
So you were finding, Alan, that you were limited in terms of your general mobility and just day-to-day activities, or just not being able to participate in sports or more vigorous stuff?
Day-to-day activities were becoming harder and harder. Just walking up and down a flight of stairs was down to sideways, one step at a time.
Oh, wow.
It was extremely painful. And then it's amazing, after the first one I had done, it almost goes away. As soon as you're able to go up the stairs again,
Yeah.
it's like, you know, that pain is gone.
So you had tried medical therapy, you had tried physical therapy, some other things, like Michael pointed out.
Yeah, shots
Right.
to try to help lubricate the joint or whatever that's more your, whatever it is. A
So you did a lot of other things.
lot of other things.
Yeah.
He also told us that he had had problems and surgeries before and injuries before to the knees. That helps predispose you to degenerative knee disease later on, doesn't it?
Yeah, it does. It's the reason you have surgery, hopefully, is because you've had a trauma to the knee. So there's repetitive traumas to the knee, losing bits of cartilage, damaging the cartilage along the way. The cushion begins to wear and break down, and that's when you get to bone on bone and climbing stairs sideways.
So how about his job as a fireman? Did that help contribute to this?
I don't want to get in trouble with this.
No. Hey, workers' comp stuff aside, really just think of being on your feet all
Yeah,
the time and climbing and.
Sure.
No question, those kind of strains put a lot more on the knee than a desk job. So.
Yeah. And if you blamed your parents too, right? You actually said that.
Yeah, I'm
Yeah.
afraid so. Afraid so.
We also probably see it in folks who are heavier than they should be, right, due to an inactive lifestyle. Do you want to talk a little bit about that, and what kinds of surgical candidates do those folks make?
So
as
you're
opposed
damned
to-
either way.
Right,
Active
if you're
lifestyle.
overly active. No, I see
You're
the
dead,
irony
right.
in that. So you have to be kind of middle of the road.
Yeah.
But
In moderation, everything in
Right.
moderation, right?
So the dictum still holds. You want to be as old and as thin as possible before you get your knees replaced.
as old and as thin as possible.
Right,
Okay.
because knees have a certain lifespan, and the heavier you are, the more force you're going to be putting on those knees. You don't want them to loosen. And getting to that point, heavier is worse as well. The body sees 5 to 7 times your body weight every time you climb a step. So if you're 20 pounds overweight, that's 140, getting
Wow.
put on the back of your kneecap, and that causes incredible forces. So weight loss is definitely, for people that are having pain, losing 10 pounds can be dramatic.
But that's sort of the catch-22, right? Because these folks are also suffering from a lot of pain, and it makes mobility nearly impossible. So other than severely limiting diet to get to that goal, it's tough. I think it's
A lot of counseling
that's a
right
tall
along
order.
those lines. This is like the conversation I have in my office every week.
yeah.
So it sounds like, though, a fairly long process one goes through before you get to the point of knee replacement. Over what period of time does that usually progress from the first aching of the knees to the point where or does that vary by patient?
Yeah, it does vary. Generally, it's 5 to 7 years, kind of where you begin to get a hint, but I've had people that have toughed it out and then come in at the last straw minute. Some patients are like that, and others are pretty dedicated to doing anything but, and they put it off forever. So it's an unpredictable pace at which it goes.
When did you know, Alan, that you were going to need to have this done at some point?
Probably my last arthroscopic surgery I had 6 of them over the years, and the last one, the doctor said, that's about all that could happen inside your knee.
Okay. So you were told.
As you took the last bit of cartilage out,
Pretty much.
he said, that's it.
He said, you're looking at knee replacement in the future, so it's a matter of how long you
Yeah.
could take the pain before you go to that next step.
Do you
Yeah.
think you put it off too long, or do you think you got it about right for yourself?
I think the first one, the pain was excruciating. I probably could have done that a little sooner.
So
but-
knowing what you know now, you might have gone a little bit earlier.
Yeah, and that's the caution I think a lot of patients need to know is not to wait too long, because I'm sure Dr. Lynch could tell you some horror stories about what happens if you do wait too long. I guess it's a lot harder to do, and from what I
happens, like,
understand.
do you get muscle atrophy, or what are the problems with waiting till that beyond the last minute?
It's like when your brakes wear out completely, right, and you're driving
Yeah,
the rotors.
then you need the rotors and the axle as well, and
Yeah.
it's a very similar thing. The best predictor of postoperative range of motion is preoperative range of motion. So if you
Explain what that means to people who.
So how much you can bend and flex your knee. So if you let your arthritis go to the point where you become contracted and your knee is stuck at only not able to straighten out all the way and can't bend to a right angle, then it's harder because all the muscles get used to that and the ligaments get used to that. So you put in the new knee, and on the operating table it moves well, but everything kind of resorts back to that stiffness. And there can be bone loss along the way too. So as the wear is happening, you can work a hole into the knee. Don't have as much substrate for me to work with to create the new knee. So those are two.
So there's some real advantages to not toughing it out,
Right.
but reaching a logical point where conservative measures have failed and where knee replacement is appropriate.
And folks are worried about having surgery. I mean, that's the main reason everybody puts this off, right? Because they're, surgery, everybody takes that with a grain of salt. Should they be worried? I mean, how quick, what is the recovery time? What's the hospital stay like? Tell us a little bit
Maybe have
about
Alan
that.
tell us, because
Well,
you went through it.
He remembers the talk. There's a dark side to any surgical procedure and to knee replacement. So there are complications where you might not hit the goal you were at. I tell patients 90% are thrilled, less than 1% have problems that wish they hadn't have done it, and 9% fall into I'm better, but it's a kind of a stiff or sore deal. You remember those talks?
I do.
Yeah.
I do.
So surgery should be entered with caution and with good counseling from your surgeon to talk about what the options are and what else could be done to manage the pain prior to that.
What was your biggest concern going into the surgery? Do you remember?
The unknown was probably, I'd heard about this type of knee a couple of years prior to it, and it is exactly what I had in my mind would be right for me, and I was hoping that it would be, and when I found out it was great. Just going into the whole thing not knowing
Sure.
what to expect
Yeah.
was very, I guess, nerving.
Yeah, and by this kind of knee, you mean the surgery that we're going to talk about in the next segment, which was basically custom designed
Yeah.
for you.
I think that's really the end. Yeah, we plan to get into immediately in the next segment.
Yeah.
But maybe during the next segment, Mike, we can have you tell us what a knee replacement is, because they're really not replacing the whole knee, you're resurfacing it. And then we'll get a little bit more about this new technology, which is really so interesting and so exciting. So
Yeah.
we'll be back after this short break. Hi, Vicki and I are back with Dr. Michael Lynch and his patient Alan DePietro. And we're just talking about your surgery, and you decided to have surgery. Was it a tough decision to make, or you were just ready for it and had come to grips with it? And tell us a little bit about I think you had a class or something ahead of time, so you knew what to expect.
It was a tough decision, but part of the prerequisites to having the surgery is you're required to go to a informative class or informational class. It's at the hospital, at the knee or the joint replacement floor that is in Norwalk Hospital, which is unbelievable. And they really go through from beginning to end what to expect, what you need to have, how you change your socks, and pretty much go through the whole gamut of what to expect.
So you didn't have any surprises, or many surprises?
Not many. I
afterwards?
know there's always something that, you say, well, I wish they told you about that, which is good because you go back and tell the people there, and they're very receptive to learning, and some experiences that you might have had that might make it easier for the next person, is which I'm a big advocate for.
So your experience after the surgery was reasonably good?
It
in
was.
general?
It was pretty much for the most part as explained. Being on a floor where there's just joint replacement was exceptional because the people there are dealing with that day after day.
That's a good point.
And it's not sick people there either, which made my wife very happy because you
Right.
worry about infection, and the doctor warns you
Sure.
about that. So it's a big enemy of this, and that's very comforting as a patient. It makes the decision a lot easier to go forward.
So it sounds
but,
like
yeah.
that the surgical floor then, the joint replacement unit at Norwalk Hospital is specifically tailored, obviously, to take care of patients like this.
And just put a plug in, I think they're a certified, Joint Commission certified joint replacement program, which is held to higher standards than most joint replacement programs, and requires special certification from the outside.
Physical therapy twice a day. It was
And there are quality metrics that they have to meet, certain larger number of patients go home, as you did, rather
Yeah.
than going to
Right.
rehabilitation. But let's talk a little bit about the surgery, because we keep talking about joint replacement. And let's go inside the OR a little bit. Tell us what really is happening when when one gets joint replacement surgery, and leaving enough time to talk about this technology.
All right, well, the most common misconception I think people have, and I'll use this model to help to show it a little, is that, and this is of a knee replacement in place, is that we take the person's knee out and put in a new one, because after all, it's joint replacement surgery. But it's easier to think of it as joint resurfacing surgery, because we really only shave the end of the bone off and put this metal
So
cap
what looks
on.
like bone is really bone in the patient and is left
You
behind.
still keep your knee, you just get a new bearing surface. And on the tibial side or the lower side of the knee, the same thing. A flat cut is made and a metal plate to support this plastic insert. So you go from bone on bone to metal on plastic.
And that relieves the pain, because the bone on bone is what causes the pain.
The bone on bone is breaking off debris, there's causing inflammation, and that's what creates the pain.
So it's a resurfacing operation. So it would seem to be important then that the pieces that you use, the metal and the plastic, match up with the patient's knee. And maybe you could take it from there as to how things are different, a little bit different now.
Sure. There are a few things that need to be accomplished to have a successful knee replacement. One is that there are often some alignment issues. People are either bow-legged or knock-kneed, and that overloads one of the compartments.
Yeah.
So the main thing to accomplish is to get that person in alignment so that their knee centers under their hip and over their ankle. And then you have to shape and match the prosthesis as well as possible to the patient's knee. And there are various ways to achieve that alignment. I use a computer-guided system, and one system that I use that helps us to get that alignment. There are various jigs that could be created and 3D printed that fit right onto somebody's knee, and then gives them the slot to generate that with it pre-planned. This technology takes it one step further, because then we talked about fitting the prosthesis to the patient. This company takes a CAT scan and takes that information and applies algorithms and actually generates and 3D prints the patient's own prosthesis. So we're not trying to shape the knee to fit one of 8 stock sizes. We're
The
shaping it
prosthesis
just...
is shaped to fit the knee.
That's right.
That makes so much more sense.
And let's bring
though.
up, we have a graphic that I think shows,
Yeah.
or some graphics that help us take us through this process. But
Here we
so
go.
tell us what we're looking at here, Mike.
So this is the CAT scan. That's a portion of it, so that the engineers, you can see the 2 little green lights out there, they pass it at various levels to get a sense, and they do it of the hips, of the knees, and of the ankle, and that's what helps them with that alignment.
And then the next, sure.
And then this is the actual, somebody watching over as these nylon models are 3D printed. So this is the material. It's a material, but for the, obviously we can't use that for the prosthesis. That gets cast in
So this
sand.
is actually, what's interesting, and I think for folks, this is an application of 3D printing.
It's 3D printing, that's
Which
right.
is really, you know, I didn't realize that it had made its way into medicine yet. So, and by the way, CAT scans, people may think of the CAT scan as 2-dimensional, but the computers can reconstruct all those slices into a 3D image.
That's correct.
So you're able to do this. You say the engineers, this company has engineers then that sort of back calculate
Engineers
the way
coupled
that-
with orthopedic surgeons, coupled with myself putting my input as to what my philosophies are on realignment, and so we all work together to get this.
And what are we looking at here?
So now that nylon piece has been made, placed in sand, cast out of cobalt chrome, and now there's this is being worked and smoothed and fine-tuned, but that is somebody's prosthesis, and that doesn't fit in anybody else. That fits in that patient that it's being designed for. That's on the tibial side, and you can see that archway. That's the femur being checked for imperfections and being brought through its final stages of preparation.
And the last one?
And this last one just shows the advantages. On the left is representing best you can fit to that patient.
So sort of the
and
standard.
and there might be a little overhang of the tibia, and there might be some bone exposed above. Whereas with this technology, everything is capped and full in, and it's really just take off the bare minimum amount of bone and get it resurfaced along the lines of the patient's own anatomy. And they move more like a normal knee, they bear weight and wear less.
Alan, were you aware of this? You said you started waiting around for this. Were you actually aware of this
I wa-
customized?
Yeah, I was. I had heard about it. And when I finally made the appointment to go see Dr. Lynch, he's telling me what he's going to recommend for me. And I'm like, the 3D knee? He's like, yeah. He was like, he was surprised that, like, you know about it.
And give yourself a plug. This is not available everywhere at this point, is it?
No, it's not. As I said, there's a lot of ways to skin the cat, and there's some tremendous technologies out there. But this particular technology, I think, is in three places in Connecticut right now.
And then they can get it. Somebody is at home, they can call that number, your office number, or Coastal Orthopedics, and set up an appointment with you. Well, why were you attracted to the 3D knee, Alan?
Well, I'm a gadget man, and I'm a big advocate of technology. And in my mind, I'm thinking that the technology is going to be better all the way around. Recovery is going to be quicker. This is what I'm thinking, and the doc could confirm it or deny it, but recovery is going to be quicker.
Recover faster than you did.
So. Yeah.
But it's also intuitive, right, Mike? I mean, we try to tailor our therapies now so much to individualized therapy. You know, we know this with cancer therapies, and we talk a lot about that on the show. But orthopedics, no different. I mean, it makes intuitive sense that you want to tailor the gadget to the patient.
An elegant science.
Yeah, it really is. Bringing you out of the dark ages.
There's an elegance to orthopedics now that wasn't there, the old saws and hammers day.
But this really is, it really is beautiful. I mean,
Yeah,
you're thinking
really.
you're taking 3D technology and really tailoring it to that specific patient. There's something really beautiful about that. It makes me very happy.
So this is a more natural fit then for the patient, and you said it gives you a lot of potential. We don't have a lot of experience with this yet. I don't mean you personally, but I mean it's only been around 3, 4, 5 years. So we don't know 20 years later how these joints are going to feel, but we're assuming that they're going to wear less and last longer.
Yeah, and there's good data in the lab to prove that that's to be expected. But that's the trouble with something like a joint replacement that you want to last for a long time. To get the accurate data as to whether it is or not, you've got to have studies that have run out 20, 30 years.
Is this good for everybody, or is it more for the younger athletic man
Right, I
or
was going to
woman, I
ask
should
the
say?
same thing, right? Or is there somebody who shouldn't have this?
This particular technology is good for a large number of the patients that need total joints that I see. If you've got a ligament that's missing, or you've got severe deformity, so if you're knock-kneed to the tune of 30 degrees or so, this is not quite powerful enough to get those corrections. There is technology available for that, but you have to add extra little gizmos to make up for a missing ligament and to lock the two pieces together, or to add wedges so that you can make up for some bone loss with a piece of metal, and that hasn't yet. I'm sure they're
So
working
even for
on
the
it.
elderly patient who may be less athletic or less mobile, you would still recommend a 3D joint?
Yeah, because they've been so innovative with their instrumentation. These are some of the instruments that have to go into the knee. We can make our incisions smaller. We can push the muscles aside instead of cutting them, and get this in there so there's less trauma, and that helps the young person, and it helps the old person as well.
Bringing in the reality of cost to the equation, is this covered by insurance the same way that traditional surgery would be, or not necessarily?
It is. The reality of cost is that they all come in at the same number. So if this manufacturer wants to be competitive, they've got to come in at the same number. Nobody's going to buy up to this.
Okay.
And we have maybe 15 seconds left. Alan, are you happy you did it so far?
Very
Yeah,
happy.
you have 2 of them, right?
Two of them.
Did you get a break on the cost?
I don't know.
There is no break.
You're looking for it, right?
And
No,
you're about 5 weeks out of your
Yeah,
last
5
surgery?
weeks
The second
out.
one is 5 weeks, and this one's 11 months.
Wow.
So, and what are you doing now? You able to walk stairs? And
I'm just starting now because, it's just not that long after. But yeah, I can go up and downstairs.
oh,
It's
congratulations.
amazing.
That's just thank you for coming on the show.
Thank you.
When
Yes,
we
this
come
was a
back,
great
we'll have
show.
today's health question.
Right now, let's look at some of our future events sponsored by Norwalk Hospital. This week's health question is, how can people prevent knee problems?
We have the perfect people here to answer that.
Yes.
Dr. Michael Lynch, how do we prevent knee problems?
Don't get hurt. So pick your parents well. Stay lean, warm up well before activities, make sure that you're dressed and have the right footwear for things, and think before you jump.
How about jogging? People talk about jogging. Is that a risk factor for chronic knee disease, or does the strength and endurance help you?
You'll remember Dr. Brody, he was a Marine Corps, one of my former partners. He was a Marine Corps marathon physician for years. Nobody's ever proven that long distance running in and of itself is detrimental to the knee. If you're doing it on top of pre-existing problems, that's a different story. But just in and of itself.
And skiing, my great love, same thing.
In the lack of injury, it's
Right,
it's
but you get an
perfectly
ACL
fine.
tear, and then all bets are off.
Should we be telling our young athletes anything different than what we've been telling them all along, which is go out there, play hard, be competitive?
Play hard, be competitive. I mean, there are some programs out there, for instance, anterior cruciate ligament tears are more common in females than males. And there is some data to show that through physical therapy programs, teaching females how to land and jump and do things can possibly prevent that, because they do have anatomical differences that can overcome. So there are
So we
some
ought to keep our eye
proactive.
on that, and maybe
Yeah.
talk to the coaches about that with all the young women, and we've run out of time. So,
Thank you.
if you at home have a question you'd like to ask Vicki and me on Health Talk, please contact us by email at healthtalk@norwalkhealth.org.
We would like to thank today's guests, Dr. Michael Lynch and Alan DiPietro, for coming on our show.
Vicki and I will see you next week on Health Talk.
Stay well.